Sir, we are live.
Okay, great. Good evening, everyone. I am Dr. Ronak, and I welcome you are all here today for the Cardiac Summit, Transforming Post-MI Outcomes with RAS Inhibitors. It's been a good weekend. I think all of you must have enjoyed your holy celebrations as well. So, after that, I think this is a good time for us to discuss something about how RAS inhibitors are transforming post-MI outcomes. Without further ado, I would like to introduce Dr. Jagdish Hiramat. Sir doesn't need any introduction, definitely. Sir is the director of Cath Lab from the Ruby Hall Clinic. Sir is also the chair professor of the Preventive Cardiology MUHS. Sir is in cardiology practice for more than 34 years and has been a pioneer in the work of coronary angioplasty and heart transplantation. So, with his rich experience, we welcome you here, sir, today. Apart from that, we also are connected with more than 15 plus locations physically, where we have Dr. Jai Kishan Naidi from Mumbai, Dr. Ajmal Khan as well from Mumbai. From Pune, we have Dr. D.N. Ambire. From Kolhapur, Dr. Shekhar Bhise. From Delhi, Dr. Ankit Jain. From Bhopal, Dr. Rahul Jain. From Hyderabad, we have Priyatham Reddy. From Vijayawada, we have Dr. R. John Satish. From Chennai, we welcome Dr. Nagendra Bhupati. From Bangalore, Dr. Madhusadan. From Coimbatore, Dr. Ramraj. And from Kolkata, Dr. Ariom Kra. So we welcome all of you here as well today. And with this, I would like to hand over the dais to Dr. Hegemat. Sir, over to you.
Thank you, Dr. Ronak. Good evening to you all, those who have joined from the length and breadth of this great country. It's Saturday evening, Dr. Polter. It's about 7:30 p.m. So it's time for celebrations as well. So we'll delay that for 1.5 hours because we all look forward to deliberations from you and Dr. Ashwani Mehta. Uh, ACE inhibitors, we know, took a back seat as for heart failure management as with the insurgence of ERNI. I think it's clawing back to its position, especially in regurgitant valvular regions and the post-MI space. The post-MI space is still ruled by ACE inhibitors, and that too, where it can compete with ARBs. We know that scientific data is enough to in favor of ACE inhibitors. So to deliberate on all this, to get experts' opinion, we have two great stalwarts who will be discussing all these aspects with us. And maybe at the end of the lectures with a panel discussion, we'll bring out some of the other nuances of this molecule. We have Dr. Neil Porter from London. I leave that slide on for you all to read. We've been listening to him for a period of I think, more than a decade in various conferences, various fora in India and abroad. And I'm amazed by the conviction that he carries in what he says. And that conviction, of course, comes from his good scientific background in which he's involved in so many research, original research papers. And that research background probably gives him phenomenal conviction. He's looking forward to a rugby game today in England, which is probably more popular than cricket is in India. So you won't hold him back more than 9 o'clock here or 3 o'clock in London. Dr. Ashwani is a good colleague from New Delhi. He's from the Sir Gangaram Hospital and with experience of more than 25 years, presented more than 200 papers and a principal investigator for 25 major international clinical trials. And some of them, like Paradise, Paragon, Emperor, are the ones which are very prominent. And I'm sure with his insights, we are all going to get wiser at the end of this session. So I invite Dr. Ashwani Mehta to start his presentation first, and then we'll go on to Dr. Neil Potter. You are on mute, Dr.
Yeah. Thank you so much, Dr. Hiramat, for the kind introduction. And I think it's a great honor for me to be here with Professor Neil Poulter and also Dr. J.S. Hiramat. Well, I'm going to just set the context. If you can allow me to share my slides.
Sure, sir.
Sure. So I'm going to talk a little bit, setting the context regarding the our own cardiac scenario in the country, and how we have myocardial infarction, various approaches treat myocardial infarction, and what we are doing post myocardial infarction. So if we look at the country, we all know number of studies have been done which have shown that in our country we have a much morbid kind of coronary artery disease, and the presentation usually is in the form of acute coronary syndromes. Among that, myocardial infarction is a big chunk, and we have this disease about 10 years earlier. And if you look at the India's age standardized death rate for cardiovascular disease, it's about 282 deaths per 1 lakh, with a range of 264 to 293, which is much higher than the global figure. And it has a huge challenge. The challenge is economic burden and also the loss to the families, which is there. Now, if you look at our country, the sheer size means a great geographic diversity. And not just that, it's a lot of economical diversity as well, and a lot of infrastructural differences. So on one hand, we have people who are in the big metros, who have access to state-of-the-art clinics and the hospitals, and most of them are treated with primary PCI. But a large chunk which is there, which is not treated in these particular areas, is in the tier 3, tier 4 cities, tier 2 cities also. Usually today we have a lot of cath labs, but a major chunk is still not getting primary PCI, and many of them are either thrombolized, or unfortunately a large chunk of them has challenge of getting correct treatment, and they are just being diagnosed late. So in our country, the presentation of ACS as a STEMI, we have two registries which are very old, and it showed, the CREATE registry showed that about 60% of ACS are constituted by STEMI, and the Kerala ACS registry showed about 40%. And this is in contrast to the international registries, which show STEMI to being just 1/3 of all ACS patients. And the another interesting fact is that the case fatality rates in our country, if you look at the Kerala ACS, it was 8.2, which is much higher than the GRACE 7 and the EuroHeart survey of 6, but similar to what it is there in CREATE. And this is what it makes it quite challenging. Now, if you look at our country, we know the incidence is increasing, and we also know that most of our patients are having a lot of financial burden, and in majority of them, it is out-of-pocket expenditure, and which is many times over their household earning. So in our countries, like I said, in big cities, we have primary PCI. In small towns, it is usually the hospital-based thrombolytic therapy. There are challenges. In fact, in the diagnosis, a lot of time is wasted, and then many of them would have failed thrombolysis and undergo a rescue PCI. In the villages, usually it is thrombolysis in the nearby hospital, and they would follow a pharmaco-invasive therapy. And many of them ultimately are referred now for the rescue PCI, or even for a PCI later. The challenge is that a large chunk of our patients who have undergone a myocardial infarction, they still have residual problems in the form of left ventricular dysfunction, in the form of valvular regurgitation. And here, we know the foundational drugs which are there, as we say, for these patients, like the antiplatelet agents, statins, beta blockers, MRA. But the RAS inhibitors are a big chunk. And whether they are being given appropriately, we still are not sure. And we know that many of them are not on the drugs which should be benefiting them, or in adequate dosages. And why so? Because this is one big area where we need to have improvement. And post-myocardial infarction, we all know there is a activation of adrenergic nervous system, RAS and cytokines. And ultimately, if we take care of that, we can take care of a lot of left ventricular systolic dysfunction. And in fact, the remodeling, what all happens post-myocardial infarction, which is due to negative prolonged adrenergic activation in the form of hypertrophy, cardiac muscle injury, and vasoconstriction, with appropriate drugs can be taken care. Today we have post myocardial infarction scenario whereby we have ACE, we have ARBs, we have ARNI. Still, we need clarity. And today we have a stalwart in the form of Professor Polter, who is going to clarify a lot of these issues. But one word I'd like to add on here, that for the sake of convenience, we do find a large number of our patients being on ARBs post myocardial infarction. Are ACE and ARBs same? Are we missing out on something? Well, it could be. The ACE inhibitors not only block the conversion of angiotensin 1 to 2, but what they do is they increase the bradykinin levels by preventing the degradation further. And then what this bradykinin does, there are a lot of other benefits which are there due to that and which might be contributing to the advantages over the ARBs. And mind you, we did a survey in Delhi post myocardial infarction. To our surprise, what we found that just about 20% patients were on ACE inhibitors, and that too on a minuscule dose. And this had about a total patient base of about 11,000 patients in various hospitals. And the ARB was the predominant way to treat post-myocardial infarction, and a minuscule amount of patients, about 1% on ARNI also. There are different outcomes which are there, which we do see with all these drugs. But to take this forward, like I said, we have an eloquent speaker who is going to follow my talk. And with this, I'd like to hand it over to Professor Hirema to take it forward.
Yes, that was a great context setting for the evening. I think we'd all now look forward to Dr. Neil Polter to elaborate on these issues about the role of ACE inhibitors in the peri-MI space and what scientific take homes that we have related to this issue. Dr. Neil Polter.
Thank you very much indeed, Dr. Herima, and my warm thanks to the organisers very much indeed for inviting me to talk to this huge, well-informed audience, and a pleasure to be with colleagues both on the dais and around India. So, following the main title of the meeting, let's talk about transforming post-MI. I'd like to think I haven't got a conflict of interest. I beg your pardon, let's go back. I'd like to think I haven't got a conflict of interest, but I show this for political correctness. By way of background, I wrote this about 10 years ago now, that because cardiovascular disease affects a third of adults in the world, it's the largest epidemic ever known to mankind. Salim Yusuf wrote that, I should say. So that's by way of background. And of course, what's the major predictor of that is raised blood pressure. It continues to be the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths each year. And that situation, as in what is almost 10 years ago now, has got worse. By 1919, it was 10.8 million. That's over 30,000 deaths per day due to raised blood pressure, which is far greater than COVID ever caused at a daily rate. And bear in mind, COVID deaths are essentially disappeared. These deaths are going to get worse. And indeed, by 2021, it's come to 10.9. And the most latest data to be published soon is over 11 million. So this is getting worse. Whatever we're doing for blood pressure, we have to do it better. But first of all, how does hypertension kill us? And this puts in perspective the main cause. As you see here, the first column is ischemic heart disease. Then we go to stroke, ischemic stroke and hemorrhagic stroke. There are more ischemic strokes, but they're less fatal than hemorrhagic stroke. But putting them together still is less than ischemic heart disease than other cardiovascular disorders. Now, before we get on to some specifics about blood pressure lowering agents, I think this is a brilliant table in the ISH guidelines, just saying what the ideal characteristics of the agents that we want to use for high blood pressure. First of all, ideally you want them to be evidence-based in terms of morbidity and mortality, i.e. in terms of cardiovascular outcomes. That's what we'd like. Secondly, we should be using once daily regimens which produce 24-hour blood pressure control. We shouldn't be using BD regimens and TDS regimens, captopril, enalapril, all those things that we used to use twice a day, 3 times a day. We should not be using those agents if there is a 24-hour agent that's better. Thirdly, we should use treatments that are affordable or cost-effective relative to the other agents, because people can't afford it. We've heard about the cost issue in India. Fourthly, they've got to be well tolerated, and that's obvious. If they're not well tolerated, then people won't take them, particularly if they can't afford it. And finally, we want the evidence of the benefits of the use of the medications we use to have been demonstrated in the populations to which it's applied. In this setting, and I'll come back to an extent, in the Indian population, in the South Asian population, it would be good to know that whatever we choose is being shown in cardiovascular outcomes trials to be the best. You saw this earlier. And the big question is, you know this, that the ACE inhibitors work on both these sets of mechanisms, whereas the ARBs work over here. They have different mechanisms, they're related, but they're different. And the question is, do these different mechanisms, laboratory-based information, do they reflect about what happens in trials, in reality, different effects on our patients? And I'll show you the evidence which persuades me that I prefer ACE inhibitors over ARBs. And this, I guess, is the bottom line, the simple one. These are 4 meta-analyses, 1 in hypertension, 1 in diabetes, 1 in coronary artery disease, and 1 in high-risk patients, comparing the impacts of ACE inhibitors and ARBs on all-cause mortality in the trials. These dark blobs to the left are the ACE inhibitors, all showing significant benefits on all-cause mortality in these 4 subgroups to the left. Notice the impact of ARBs. No benefit, no significant benefit, no significant benefit, no significant benefit. And actually 2 going in the wrong direction. These are the data from the trials of ARBs on all-cause mortality. Well, you may say you don't like meta-analyses, so maybe we should look a little more carefully at some individual trials. And I'll mention a couple. This is one I think is particularly relevant, is the HOPE trial on the left, using ramipril against placebo, and it worked. Here you see in these high-risk patients, ramipril giving a 22% reduction in the primary outcome of MI, stroke, and cardiovascular death. Big benefit. This was a huge hit. Ramipril given at night at the time when it was first published. Now, then people said, well, okay, if the ACE inhibitors worked in this high-risk population, let's do the same thing with telmisartan, an ARB, a long-acting ARB. Remember, ramipril is relatively short-acting compared to telmisartan. And here they looked at the same sort of outcome, same design, high-risk people, telmisartan versus placebo, and no significant difference. 22% versus 8%. Which would you take if you were in that setting? So now let's go to some of the guidelines. On the basis of all this stuff, and I apologize, I'm going to show you cuts from the guidelines because we don't have time to go through all the data. But here you see, a couple of years ago, the ESH guidelines for managing of high blood pressure in patients with hypertension and coronary artery disease. And they said use an ACE inhibitor, but if you can't tolerate that, you might try an ARB plus a beta blocker. And you increase the full dose if it's well tolerated. If you've got angina, add in a dihydropyridine. If you haven't got an angina, you can add in either a dihydropyridine or a diuretic to get to the right blood pressure level. So that's very simple. And no doubt in the mind, you start with an ACE and a beta blocker in that setting, but only if you can't tolerate the ACE do you use the ARB, because the evidence to support the ARB is not as good. Now let's go 1 year closer to now, the 2024 ESC guidelines for managing elevated blood pressure and hypertension. And the recommendations: patients with a history of MI require blood pressure lowering treatment with beta blockers and RAS blockers, and there they don't differentiate. We'll come back to that. In patients with angina who require BP lowering treatment, beta blockers or CCBs, we all agree with that. And then you get into HFrEF and moderate levels of ejection fraction damage. The following treatments with blood pressure effects are recommended to improve outcomes: ACE inhibitors or ARBs if not tolerated, or ARNI, beta blockers, MRIs, SGLT2s. And we'll mention some of the data of these others. But once again, it's ACEs first. And if you can't tolerate an ACE, then you may use an ARB. In patients with symptomatic HFpEF, SGLT2s are recommended, and I'll show you some other data about the LGP1 agonists. 2023 ESA guidelines for managing acute coronary syndromes. Well, we all agree that beta blockers are needed there, but as far as the RAS system inhibitors, ACE inhibitors are recommended in ACS patients with heart failure symptoms. LV, left ventricular ejection fractions under 40%, diabetes, hypertension, or CKD. ACE inhibitors, not ARBs. Mineralocorticoid receptor agonists are recommended in ACS patients with reduced ejection fraction or heart failure or diabetes. And routine ACE inhibitors for all ACS patients, regardless of ejection fraction, might be considered. But once again, the focus from the guidelines based on the evidence is on the ACE inhibitors. Right, what about angiotensin-converting enzyme inhibitors with chronic coronary syndromes? Well, here they say in chronic coronary syndromes, ACE inhibitors, in brackets, or ARBs if not tolerated, are recommended for the presence of specific comorbidities such as hypertension, diabetes, or heart failure. And ACEs can be considered in chronic coronary syndromes at very high risk patients, at very high risk of cardiovascular events. So once again, the emphasis is on the ACE. Not quite so recent, but essentially covering the whole area. This is the summary of a review, a critical appraisal and comparison of all the international guidelines, comparing ACEs and ARBs. And whilst they agree they're the two main classes, we're not talking about direct inhibitors here. They both effectively reduce blood pressure, and that depends on the dose and which ones you're choosing, incidentally. There's some misbelief that ARBs are more effective at lowering blood pressure than ACEs. That is not true. It depends which ARB and which ACE you choose. However, this is the bottom line. Clinical evidence suggests ACEs and not ARBs provide additional benefits before blood pressure control with regard to reducing cardiovascular and mortality risk in patients living with hypertension and other cardiovascular morbidities. So that sort of summarizes the guidelines, many of which I've showed you some information. What about the ESC guidelines on diabetes? Now let's go into a different area, diabetes and pre-diabetes. What do they say about their guidelines for management? And they say ACEs should be used in the management of hypertension, or ARBs, who are intolerant of ACEs, and recommend ACEs to prevent major cardiovascular events in all patients with chronic coronary syndromes or acute coronary syndromes and systolic left ventricular dysfunction. Okay, so the diabetologists agree with what I've been saying. Most of the other guidelines have said too, ACEs rather than ARBs. And let me just show you the thing that really stopped me using ARBs in diabetes. This was the roadmap trial, 4,500 patients with type 2 diabetes, but they had no albuminuria. The trial was designed so that patients received olmesartan 40 milligrams against placebo, randomized to that, and overall the reduction associated with olmesartan wasn't big, it was 3/2. The primary endpoint was new onset microalbuminuria, and in my mind that's fool's gold, but we could have an argument with nephrologists about that if you like. But that was the primary endpoint. The patients were followed up for just over 3 years, either on olmesartan or placebo. And there you go, the primary endpoint, new microalbuminuria, was significantly reduced, 23% reduction reduced if you got your olmesartan. Woo! But now look at them things that really matter, all-cause mortality. That was significantly reduced, I beg your pardon, significantly increased by 70% if you were on olmesartan rather than a placebo. This is rather than a placebo, but it wasn't statistically significant, so the numbers are small, so we must interpret that with caution. On the other hand, if we look at cardiovascular death, there was a 5-fold increase in cardiovascular death associated with olmesartan, and that was statistically significant. And for you, I know many of you are cardiologists, you'll be particularly interested in sudden or fatal MI. The numbers involved were 12 if you're on olmesartan and 1 if you're on placebo. And it was these results really which got the New England Journal in their conclusion of the abstract when they published this as a success story because it reduced microalbuminuria. But the higher rate of fatal cardiovascular events with olmesartan amongst those with pre-existing heart disease is of concern, absolutely is of concern as far as I'm concerned. That stopped me using ARBs in anyone with type 2 diabetes. And that's typical, if you don't mind me saying so, of what we've seen in several trials. The trials are on the left there, but the heading is what I want you to take home. And that is that the ARBs are missing or they've failed where the ACE inhibitors have succeeded. Few examples. HIVET, the very elderly, where they used indapamide and perindopril against placebo, big benefits on recurrent stroke, on all-cause mortality. There are no trials of ARBs in the very elderly. So why use them? HOPE, you've seen these data, HOPE versus TRANSCEND, I showed you that earlier. Ramipril at night, the primary endpoint, cardiovascular mortality, all-cause mortality was significantly reduced by Ramipril, but telmisartan in the same trial showed no significant benefits. Post-stroke, perindopril indapamide, so ACE plus thiazide-like diuretic, significant reduction in recurrent stroke. Let's do the same thing with telmisartan in people who've had a stroke. Telmisartan versus placebo, no significant reduction. Then we turn to type 2 diabetes, where in type 2 diabetes, they used a single pill combination of perindopril indapamide against placebo, big significant benefits in these people with type 2 diabetes. Roadmap, the primary endpoint was microalbuminuria. Okay, it did that, but a 5-fold increase in cardiovascular mortality and an increase in all-cause mortality. So looking at these individual trials together, I think it's very reasonable to say the ARBs are missing or fail where ACE inhibitors have succeeded in trials. So when I look at subgroups of patients, and as I pull this together for another talk and talking about subgroups of patients, those with type 2 diabetes, we've got evidence ACE plus a CCB or ACE plus a thiazide-like diuretic, none for ARBs. Established cardiovascular disease and high cardiovascular risk. Well, coronary disease, we know ACEs, beta blockers, this is what we've seen in the guidelines. Statins, we haven't mentioned them, but absolutely pivotal, it seems to me, for everyone with hypertension and established cardiovascular disease and antiplatelets. Stroke, we saw it, ACE inhibitor plus thiazide-like. But they're very elderly or those with isolated systolic, they've got evidence for dihydropyridine calcium channel blockers, for thiazide-like diuretics, or thiazide-like plus an ACE inhibitor with a high VAT we saw. For those with left ventricular hypertrophy, the LIFE trial was the only one that I know of where there isn't evidence, and that's because the trial hasn't been done. I believe the ACEs will be just as good, if not better. But in people with established left ventricular hypertrophy based on ECG, ARB plus thiazide is where there's some evidence. In heart failure, we'll come back to that, in all the various combinations. In ethnicity, there's very little evidence amongst the ethnic groups who've got most of the hypertension around the world, i.e. South Asian patients and black patients. The Creole trial showed there were preferential combinations. All the guidelines are recommending combinations of drugs, 2 drug combinations, but which 2 drugs? We don't know for black patients, and until Creole was shown, we didn't know which was the best combination for lowering blood pressure. South Asian patients, the Topspin trial was presented at AHA in November, or was it December? And it's going to be published very shortly in Nature Medicine, showing that any of these 3 combinations were equivalent, at least from a blood pressure point of view. And that was ACE plus CCB, or ACE plus diuretic, or calcium channel blocker plus diuretic. So let's just go back to basics. We start here with risk factors. Hypertension, obviously, we'll be focusing on to an extent. Cholesterol, diabetes, smoking, insulin resistance, huge in the South Asian population, working round through endothelial dysfunction, coronaries, strokes, remodeling, and right the way around to end-stage heart disease. So when we're talking in this particular lecture, we're talking here about this whole range of problems, and we don't obviously have time to go through them all. But here's the evidence supporting benefits of ACE inhibitors in coronary heart disease. Here are some of the trials of post-MI, heart failure, left ventricular ejection fraction reduced when it's less than 40%, SOLD preventive, HOPE we've talked about, Europa, high risk. So these are all CAD patients. And let's just bring a little focus onto heart failure because it's so huge as a problem. It affects more than 23 million people worldwide. Half of the people who got heart failure die within 5 years. It's as bad as most cancers. So heart failure ranks as the most frequent reason for hospitalization in older people. And though it's sort of at the end of that continuum, it's because people are old, get it, and we're living to older and older ages. And if you compare the ACEs and the ARBs and the MRAs and ARNI, what they do with hypertension, HFpEF and HFrEF, you get a different story. For hypertension, you'll reduce heart failure, reduce all-cause death, and they do that through various, or in addition, you can see surrogate endpoint data reducing left ventricular size, left ventricular function, arrhythmias, and the evidence here you see right the way across, not quite so certain there in ARNI for hypertension. For HFpEF, no benefit really of in morbidity and mortality. They've got some bonuses and you may wish to use it, and we can talk about that to an extent. But HFrEF, you get reduced hospitalization, reduced all-cause heart failure deaths and sudden cardiac deaths across the range of agents shown there. But preferentially, they're not equal. So what about recommendations here in the heart failure guidelines comparing ACEs and ARBs and ARNIs? What should we use? And the 2022 AHS heart failure guidelines said in patients with HFrEF and class 2 to 3, use ARNI to reduce morbidity and mortality. Those who've got established clinical heart failure. In patients with previous or current symptoms of chronic HFrEF, the use of ACE is beneficial to reduce morbidity and mortality when the use of ARNI isn't feasible. When we come now to the third bullet point here, also with high level of evidence, in patients with previous or current symptoms of HFrEF who are intolerant to ACE, you can use ARBs. It should say ARB there, not ARM. Because you're intolerant because of a cough or angioedema, and ARNI is not available, then ARB is there. So it's sort of a third choice. And in patients with chronic symptomatic HFrEF class 2 or 3 who tolerate ACE or ARB, replacement by ARNI is recommended if you can afford it and you think you want marginal increase and the symptoms are still prevalent. Okay, why would they come out with this preference for ACEs over ARBs? And you see here a summary on all-cause mortality in the trials on the left of ACE and on the right of ARBs. ACE inhibitors, 32 references, a significant reduction in all-cause mortality. The ARBs, 6 references, no reduction in all-cause, I beg your pardon, 15 references, no reduction on all-cause mortality. If you break the trials down, the ACE inhibitors against active drugs or against placebo, in both settings, against active drugs, there's a reduction with the ACE inhibitors, and against placebo, a significant reduction. With ARBs, no significant reduction against placebo and no references against active drugs. So you can see why the heart failure guidelines promote ACE inhibitors and not ARBs. Now, what about HFpEF? And notice the typo here in there, guys. That should say HFpEF. Patients with HFpEF and hypertension, you don't have to worry so much about the heart failure there, is what they're saying. You want to focus your medication to get the blood pressure down in accordance with published clinical guidelines to prevent the associated morbidity. Now, what's new on the block? Well, semaglutide. This was a meta-analysis of 4 trials, cardiovascular outcome trials, using semaglutide, the injectable form of semaglutide, looking at the impact in patients with reduced ejection fraction on cardiovascular death or worsening heart failure, significant reduction. On worsening heart failure, significant reduction. On cardiovascular death, not significant. 18% reduction, but not significant. So that summation, I think, makes it a reasonable choice as a potential add-on for patients who've got a degree of mild reduced or preserved ejection fraction. It looks as though, certainly from a composite of cardiovascular death and worsening heart failure, might be worth adding in to your ACE inhibition. Now, what about legacy effects? This is interesting, and it arises from the AIR trial originally, a small trial, 2,000 people, looking at all-cause mortality in these patients post-MI with clinical heart failure or shortness of breath symptoms. Within 2 to 9 days after their MI, we got placebo or ramipril, and you got a 23% highly significant reduction in all-cause mortality on those who got ramipril. And it was mentioned early, ridiculous doses of drugs. We should be using proper doses of drugs. And in the context of hypertension, that's 5 milligrams increasing to 10 milligrams, not 1.25, 6 months later going up to 2.5. However, I digress. The point about this is post-MI with heart failure, you see quite clear big reductions in all-cause mortalities in these patients post-MI. So what they then did was extend those data in a subgroup, those who were in the UK. There were multinational trial, originally the AIR trial, but this was the AIR extension study. And it looks at the survival benefit of those who were randomized, small numbers here, 302 on the ramipril, 301 on the placebo. And over time, you see here this 36% reduction in all-cause mortality in those who were on the ramipril. Much better off. If you hear, there's those on ramipril, and here you see the death rate on those who are on placebo. So 5 years on the ramipril versus placebo, big benefits. Now, beyond that, we've talked about the original trial. Then there was that sort of 5-year follow-on. But then there's the AIR survival trial that was published recently, and that's up to 30 years of follow-up, albeit in pretty small numbers by the end. So this was long-term survival benefit of ramipril in the patients with AMI, with heart failure at baseline that we had in AIR, and then they went to AIR-X. And as I said, it was those 603 people, and they followed them on. This was just an observational study looking at their life expectancy or all-cause mortality. And the bottom line was that there were substantial survival gains with the ramipril treatment for 15 years beyond them ever being on any ramipril necessarily. And overall, the size of that benefit was for every day a patient received ramipril in the trial proper, on average, his or her life was extended by a further day. So the relative risk of survival for patients with diabetes, previous heart failure, previous MI, hypertension, and angina were all significantly increased. This is very powerful data, long after the drugs were supplied in the trial. And so to summarize and conclude from the AIR survival study, the summary was that the treatment with Ramapil for about a year, when started early post-MI, 2 to 9 days, in patients with heart failure, resulted in a survival benefit which is sustained over many years. And it offered on average an extension of life of about an extra year. So I think it's a reasonable conclusion to say that we should initiate ACE inhibitors early after an AMI, particularly if it's been complicated by heart failure. So finally, ladies and gentlemen, this is how we've traditionally managed high blood pressure. We get hold of an arm and we squeeze it. And then depending on how high the blood pressure, the mercury column goes, we dish out tablets, ignoring the object that's behind the wall. Now, we need to pay attention to what the patient has had. Have they had a myocardial infarction? Have they got heart failure? Are they pregnant? Whatever else is happening, we have to take all these risk factors into account. And ideally, if you could give your pharmacy as single pill combinations, that's brilliant. And always to mention, I think in the context of hypertension, certainly, these patients should also be on a statin. Thank you very much indeed for your attention.
Thank you, Dr. Polter, for this brilliant deliberation. There is no doubt that all of us have in our mind that ACE inhibitors are better. But coming from you and with this kind of a data presented so elaborately, I think there is a conviction level is now very high, I'm sure. The relevant indications like the peri-MI period, at least 1 year following that Ramipil, is definitely the point is well driven through. I have one question for you as to a patient who is chronic coronary syndrome, that means followed up chronic coronary disease, doesn't have diabetes, doesn't have hypertension. Would you be using ACE inhibitors in them for any reason?
I confess I haven't. I think you might persuade the nephrologists if they sniff any albuminuria, they would probably give it. I believe we shouldn't be pursuing albuminuria. I think we should be pursuing the blood pressure and the glucose and the lipids first. And so my take wouldn't be, and I don't in that setting add in an ACE inhibitor. But I take your point. If we were able to treat all the ones where the evidence is good and we could afford to do it, and we did, then maybe that's a spillover. Maybe we could afford to do a trial in those people to see if they would benefit. My guess is they would, but we're under treating so many where the evidence is rock solid that we should use them, that I would hold back on that.
Finally, AIR and AIR's trial is a very old trial where revascularization for AMI was not so common. So this, with the advent of PAMIs going on and patients having probably normal LV functions at the time of discharge, would you think there would be a reconsideration, or we should continue to use ACE inhibitors in this period?
Well, I think the AIR was 1993, so it is a long time ago, isn't it? But I think it was really more the fact that those benefits have happened irrespective of continuing the treatment, which makes me think that the treatment at the time does something. It sets back the adverse clock, if you like. Whether it just stops bad things happening for sufficiently long to get the benefit down the line, how it works, I don't know. We've seen these latent benefits we saw it in the advanced trial with perindopril.
The legacy effect, yeah.
Yeah, the legacy effect. We saw that. We've seen it with statins again in the ASCOT trial. So I think it makes sense that if you make a difference to the vasculature for a reasonable length of time, but in this case it wasn't long. It was just the original trial was only 15 months. But of course, when we're talking about these trials based on something of a long time ago, we have to be concerned that the other things that we might have done would affect the results. But I think they are what we are, and I think they're just a little addition to help us to be persuaded to use ACE inhibition when we should. And at the moment, as we've heard in India, that you said that isn't happening, and it should be.
Yeah, one last question before I hand it over
to others. To Dr. Polter.
Yes.
Yeah. Is it okay if I tell, sir?
Yes,
sure.
Yeah, thank you, sir. That was a phenomenal lecture, highly educative. Hats off to you, sir. I do have a question. The point what you emphasize that taking 1 day of Ramipral, adding a line one more another day to the patient is phenomenal.
Sorry, somebody
We
else is
also
talking. Sorry, hang on. Somebody else is talking.
okay.
Okay, sorry. So go back again. I'm sorry.
The
Yeah,
point, the most
start from the
important point,
beginning.
what I took from your presentation is adding a Ramipral for a day increases another day for an individual. That's a phenomenal point. We know that ARNI is better than at least enalapril in patients with LV dysfunction, not in heart failure. Paradise MA, I am aware that Paradise MA is a negative study. These MA patients will become chronic heart failure patients after 3 months. So how exactly would you suggest us to manage such patients who have been on Ramipral or AC inhibitor from day 1 of MI? And after we are clear that paradigm shift did not include patients within 3 months of ACS. They included patients after 3 months of ACS. Do you suggest that we should consider keeping them on AC inhibitor for first 3 months and swapping it to ARNI after 3 months? Or how exactly? If Ramipral is going to increase a day, what exactly ARNI does? How long is it going to increase?
Well, as we had, let's not get too carried away with the survival trial. It's interesting, and it's maybe confounded and affected by things that have happened in the past. What we do know is that symptomatic heart failure patients, ARNI beat enalapril. Notice the drugs we're dealing with here, and come back to one of my early slides about long-acting drugs that have got evidence of cardiovascular. We shouldn't be using enalapril and captopril, but better ACE inhibitors than enalapril may well provide equivalent benefits that they saw in Paradigm in 2014, it was published 2014. Paradise, on the other hand, as you said, where there was no significant difference between ARNI and Ramipril in those who were post-MI. There was no significant difference. They didn't have symptomatic heart failure, but they had reduced ejection fraction, etc. But there was no difference in cardiovascular death. So I wouldn't be rushing to change people from ACE inhibition to ARNI. I think the judgment all round is that probably ARNI is better in the context of established heart failure. I think incremental benefit and cost comes in here is, I suspect, relatively small. Does that answer your question?
Yeah.
If I
So
can add a line.
do you think it's time to consider a randomized control trial comparing ARNI versus Ramipril in congestive heart failure patients without ACS?
I would recommend, I think, if you could persuade somebody to do it, not necessarily a long-acting ACE inhibitor, ACE inhibitor versus ARNI, yeah.
What is your gut feeling? Do you think it will be non-inferior?
I would suspect a long-acting ACE inhibitor. It's hard to tell. I think, let me say again, the heart failure doctors have come up with a statement that they believe ARNI has got the edge in that setting. And until further notice, I think that's reasonable. But the incremental benefit is limited, and there's an incremental cost difference. So I wouldn't go against that recommendation. But yeah, if someone's got $150 million handy to start a decent trial, why not? That's what it costs.
Good evening, Dr. Polter.
Good evening.
Yes.
It was a wonderful presentation from you. Very to the point, and it was very helpful actually, since the data that you touched upon. Probably, definitely, as new molecules come, we get carried away with newer molecules and don't tend to give importance to the time-tested ones. My question to you would be, sir, basically on post-ACS heart failure. What would be your preference? Would you prefer a AC inhibitor, or would you prefer ARNI to go straight away?
Well, in your setting, post-ACS is mainly in STEMI, isn't it? You've got post-MI. My guess, once again, I'm not a heart failure doctor. If I were to go with the evidence, the heart failure doctors would commit to ARNI. I think they'd give the edge to ARNI. We don't know, but I think that's the edge. So I would go with that. But as I said, incremental benefit over the tried and tested is limited.
Yeah. Recently, the Paragon HF trial concluded that AC inhibitors were non-inferior to ARNI in post-ACS LBDs.
Yeah,
So should we
I
go
agree.
with the AC inhibitors?
I agree, but if it was you, it's a matter of size. If there'd been 1 million on each side, that non-inferiority might have been statistically significant. So I wouldn't fight over the stats, and I do understand what the trial showed. But if it was you and me, what would you go for if you had just wanted the absolute best on the evidence that's currently available to you?
Probably, yeah, with the current evidence, we would definitely go with ARNI. But I don't know. Even the AC inhibitors are time tested, so probably we may not be wrong if you choose AC inhibitors as well as.
I don't think you're wrong to treat with an ACE inhibitor. Wrong would be completely the wrong word. It might be suboptimal, might be, but that's all I would say.
Might be. Thank you.
Any other question from any other city? Dr. Ashwani, you have any comments to make?
Yeah, in fact, I'd like to say it was a wonderful talk by Professor Neil Poulter, but we still don't have a final answer in post-myocardial infarction. And as far as the guidelines are concerned, they have not changed. So I'd like to ask Professor Poulter, the guidelines do not recommend post-ACS to start these patients de novo on ARNI. So we don't see any harm in giving them with a time-tested molecule like ramipril post-myocardial infarction. And cost is an issue, but generics are there now in our country. But still, for having said that, I would like to have, you said that there is nothing wrong in starting. What is going to be your first choice, if you could just make that clear?
Post-ACS heart failure, or
heart failure.
I think post-ACS, it would be perfectly reasonable to use a long-acting ACE inhibitor or ARNI. And I don't think as you say, there is no proof that one is better than the other.
Yeah.
So you have to make a guesstimate as to what you might want to do. Again, I'm not a heart failure doctor. My take is that many of the heart failure doctors will make a leap of faith if cost was not an issue and use ARNI. But I think it's perfectly acceptable to use either the ACE or ARNI in that setting.
Thank you.
Coimbatore seems to be ready with a question.
Sir, good evening, sir. Thank you for the amazing lecture. So, one question for you. So, patient with post-MI status with normal blood pressure and no history of hypertension, can we start the AC inhibitors?
Or not, you should. Post-MI patients should be on beta blocker and ACE inhibitors irrespective of their blood pressure. You have to be careful, and that might be one of the occasions when you use one of these silly doses. I get so fed up in the hypertension clinic of getting patients referred to me on ramipril 1.25 and their blood pressure isn't controlled. Just nonsense. But that might be an occasion when you could start with a low dose of ACE inhibitor when the blood pressure is already low, because that is an issue. It is a concern that you don't get too low. But absolutely, post-MI, normotensive in inverted commas, yes, beta blocker and an ACE inhibitor and a statin and antiplatelet therapy.
Thank you. Thank you, sir. Thank you. Thank you so much.
Pleasure.
Good evening, Professor Poulter.
Good evening.
My question is, should we make a differentiation between patients who had symptomatic heart failure or without symptoms? See, post-ACS, should we make a differentiation whether the patient has significant LV dysfunction with symptoms, or where we can use ARNI, or without symptoms, like when you run an ejection fraction of less than 40%, they don't have, many times we don't have symptoms also. Should we differentiate in starting ACE inhibitors or ARNI in such patients? Is there any recommendations for this? Symptomatic LV dysfunction, asymptomatic LV dysfunction.
Well, as you know, the HEF preserved, there's no good evidence for using ARNI, etc., RAF blockade. So in that setting, depending on symptoms, I think there are endless permutations and combinations of symptoms, HFpEF, HFmrEF, medium reduction, etc., all those things, and there aren't sufficient trials to give us absolute confirmed directions to what we should do. So the question is, should we, with someone who's got reduced ejection fraction but no symptoms, then yes, I would use ACE inhibition.
Yeah, thank you. That's what I was thinking.
Yeah,
Maybe you could consider using ACE inhibitors for patients who may not have symptoms with LV dysfunction post-MI, but definitely you should think about starting ARNI once they have symptoms.
Yes, symptomatic. Yeah, that's the sort of crude differential, I guess. Yeah.
Thank you.
Vijayawada.
Good evening, sir. I'm cardiac surgeon. Most of the times after cardiac surgery, there will be some cardiac dysfunction for few days. Initially, few hours it will be very severe. Then slowly it recovers, and within few days it corrects. So it not only for coronary, any cardiac surgery. How do you advise or give guidance for us to use these drugs so that they can these patients can get benefit along with surgery with these drugs?
Okay, well, we're now in an evidence-free zone, aren't we? If we're doing post-cardiac surgery, and I think you just have to treat that symptomatically ad hoc on the basis of the symptoms that occur at the time. And that would involve using diuretics, ACE inhibitors, whatever, beta blockade, whatever it may be. But I don't, we don't have the evidence to keep those people on therapy for any length of time. You might argue, and I think many would, what harm would there be apart from the cost? I don't see any harm associated with that, costs and side effects. But once they've recovered from the acute problems that you allude to, once those have disappeared, you could perhaps cut back on some of the drugs, bearing in mind the cost load to the patient in its broadest sense. But would it damage them to keep them on? Probably not. The one query about that might be on long-term beta blockade. I'm not persuaded that's a good thing for large numbers of patients, particularly because of the adverse metabolic effects. But if you are treating at the same time with statins at high dose, and maybe as we move more into the GLP-1 agonists, I think they will start to creep into our practice, then maybe you could risk being on a beta blocker, but better still take them off.
So short-term treatment is worth it. Probably it will recover and then we can.
Yep.
So any other questions from anyone? Pune?
Sir, what if the patient is already on the ARBs for the hypertension and he develops the EMI? So can we change it to the ACE inhibitors?
Yes. Absolutely. It's a no-brainer. I mean, just look at the evidence. When I get a patient comes through with type 2 diabetes and hypertension, I cannot look at myself in the mirror and say, the best evidence is I should give you an ARB, because it's not there. It is there for the ACE inhibitors. So back to your point, yes, I would absolutely change to an ACE inhibitor. The problem arises if they then cough on their ACE inhibitor. And then you've got to be careful. When they do cough, it's worth trying another different ACE inhibitor. That can work sometimes. The other thing is it goes after a short length of time. So I have a colleague who had an MI, he's had all sorts of cardiovascular. He takes an ACE inhibitor and he coughs. And he said, I'm still taking my ACE inhibitor, I don't care. He sucks a mint, was what he said. I have a mint when I cough and I keep taking my ACE inhibitor. That's a very eminent, world famous hypertension doctor. Not me, because I'm neither of those.
He's an evidence-based doctor, I think. Any more questions? Hyderabad, Bangalore, any questions from that side?
Professor Porter, one more question for you.
Yes.
What is your preference regarding the dosage schedule for Ramipril? What is the maximum dose you use? And do you prefer using it once daily, or some people can take twice daily? What is your take on this?
Well, this comes back to my dose issue with Ramipril. I think you need at least 5 milligrams to give 24-hour control. I think you should be, I use 5 milligrams and go to 10 milligrams. I never start on less than that. And in the context of hypertension, obviously, if you're slightly concerned about bilateral renal artery stenosis, which is exquisitely rare, then I will start on a tiny dose until I know otherwise. But by and large, I'll have tried to exclude that. But the answer is 5 and 10.
And the HOPE trial used it in the night. So you would prefer using it at night or any time during the day?
The evidence, as you say, the best evidence for Ramipril is in the HOPE trial, and that's what it was given at night. When it was compared with telmisartan, which is a long-acting ARB, it still did just as well as the long-acting ARB, but it was given at the daytime. And I suspect if you've got a longer-acting ACE and/or you've given the Ramipril at night, you might have got better issues. Overall, there is no evidence that giving the drugs at night is better for you. There was a big story from the Hygieia trial that giving the drugs at night was good for you. That was completely found to be untrue, not the case by the Time trial and 2 other Canadian trials. So we should be giving the tablets whenever they are most likely to be taken by the patient.
So look at the compliance and look at the compliance of the patient.
Exactly. So, Wales versus England. I hope everybody's going to cheer for England today, please, this afternoon in Cardiff.
All right. Okay, we do that. I think, Dr. Shan, you want to make any final comments before we close the session?
Yeah, in fact, I'd like to thank Professor Hiremath, Neil Poulter for the wonderful session today, and also all the people who have joined here. It was a great learning, and the longer-acting ACE inhibitors seem to be there still in vogue, and we need to continue using them. The great advantages, you shouldn't get carried away. And this is it. That's it. I'd like to say that.
Thank you. I think our own beliefs were kind of bolstered today by the presentation. We know that we should be using Ramipril once a day on correct doses, maybe a larger doses than what we are doing, to give advantage to the patient related to the entire spectrum of cardiovascular disease. I think valvular regurgitated lesions is one of the chunks we have wherein we can use more use of ACE inhibitors as well. Probably in India, the cough and the tolerability is an issue. But as I said, we have to convince ourselves that we have to overcome that. Unless it is a very resistant and irritating and probably a cough, very distressing cough, probably one would not easily withdraw a drug like Ramipril, which has such a strong scientific background. So we'll all go today with a conviction in our mind that we need to be using Ramipril in a better way, probably in more number of patients, definitely peri-MI. And you can see the extended trial we showed that even 1 year of Ramipril can give them a very long benefit related to Ramipril. So I'll stop that. Thank you, all of you. Thank you, MCure, for arranging all this.
Goodbye, everybody, and thank you all.
Thank you.
Dr. Ronak?
Thank you.
Thank you so much, sir.
Thank you, sir.
Thank you. Thank you so much, sir, for joining. And we, as from MCure, thank you all of the doctors who have joined from the physical locations. Thank you so much for taking out of your time in this evening and joining this wonderful session